because there is normal FFR before, or you respect F plug shift and do again rewiring and then FFR to see if going for kissing balloon or not.
This is another point. That is, if you have the plug shift or the carina shift, and so angiographically with a significant residual lesion at the ostium of the side branch, it's true that if we do the FFR and the FFR is non-ischemic over than 0.8, normally you could leave it. This is today the rule we have, but again it depends of the size of the vessel, the amount of cardiac, the myocardium involved, etc., etc. It depends. If it is a large vessel, for example, when you have a distal left main bifurcation, if you have 80% stenosis at the origin of the circumflex after the placement of the stent on the left main LAD, what to do, even if the FFR show you 0.84, 85, 86, if you have a critical lesion at the ostium of the large circumflex artery, giving 2 or 3 OM branches, we could do, but really, personally, I'm not feel comfortable with this strategy.
One technical question here for deciding what side branch is important. You know, some people are talking about the diameter, and because you want to know what is, for example, this is an important side branch. I mean, you can look at it, eyeball it, and you could say, this is an important diagonal branch because it has so many branches. But could we decide, I mean, deciding which side branch is important that you want to preserve? Do you go with the length? Do you go with the diameter? I think there are some talks about diameter, anything above 2.25 or 2.2 or 2 millimeter, I don't know, could be important. Talking about fluid hemodynamics and engineering concepts and important side branch. Do you have any rule in mind, like what side branch is important?
Well, it's really the basic on the experience, the visual estimation of the diameter, the size of the vessel, the length of this vessel, the amount of myocardium vascularized by this vessel. And one good thing should be if I place a balloon inside and occlusion and be occlusive of the side branch, what happened? And if you have, of course, we have immediately to in the next 2-3 minutes we have ST depression or ST elevation, yes, chest pain, etc. We will certainly move to the.
You know, it's important.
You consider this side branch as a significant side branch. So I think we have to move to the.
The only issue now is
to the field.
Yeah. Okay, yeah, that's another good show. Yeah. Okay, I think we stick to plan A.
So you choose the 275, 28 cipher stent.
It's a diabetic lesion, long lesion on the LAD. I think there is a few discussion about the choice of the stent.
And the first stent of the right was also a regulating stent, yeah, with a large ducted stent. Now it's certainly the most difficult part of the procedure to really precisely place the proximal marker of the balloon of the stent. Just
you can zoom just on the
below the origin, beyond the origin of the. It's not too bad.
Not too bad, huh? Maybe we will reconsider on the other view.
Of course, the stent. The stent begins just after the marker. It's not on the marker. Huh? This is not too bad.
When we look in this view, maybe we can, but after there is a distality, so.
I like that.
Huh? You like the position? Yeah, I think it's correct. Huh? Okay, we will deploy the stent now.
Very good.
14.
What you can do is to do an angio during the
Yeah.
the balloon inflation to see the diagonal. I think it's perfect.
Yeah. It seems to be good. We'll see
Very
after
good
the
position.
Do you inject during inflation to see where the side branch or?
Yeah, it's just to
the stand
confirm
starts
that we are
just
in
after
the
the
right
marker,
position,
so
that
should be
if
good.
it is not the right position, it's too late. The stent is deployed. But we are doing
In this
this
case, the pressure was
regularly.
moderate, the pressure inflation, or you
14
apply
atmosphere.
the high pressure?
14. What I will do now is just do a small puff to see what happens, and maybe do an additional
Balloon but inside
balloon
with the
inflation.
short stand head.
Because it's a long stent, and
Yeah.
in long stent we need to carefully deploy the stent, and maybe it requires more balloon post dilatation. So now
It
I
will be
will.
interesting. It's certainly after the angio control, maybe to evaluate by IVUS to look at the ostium of the diagonal, if the ostium is free or covered by the thread. Should be interesting.
We can do also a stent boost to evaluate the
You can see also
apposition.
the stand boost.
I inflate up to 8 to 16 atmosphere. And if they are ready, we can perform the stent boost now.
So maybe just proximally we need a little
Yeah,
bit.
approximately there is some things.
But
So maybe it should be
probably,
better to come back with a short,
A short
balloon.
non-compliant balloon.
non-compliant, maybe 3-0,
Yeah.
non
3-0, yeah.
non-compliant.
Yeah, that's not bad, you know.
You can zoom on the proximal part of the stent. Probably an additional inflation
Yeah.
will be necessary. Even at the mid part of the stent, we think just after the bend, it seems that maybe there is something also at this part.
But the
So-
crucial thing here will be to be just
Jean.
careful
Yeah.
and accurate, and you know.
Can I
to
ask you a question regarding the
use
bifurcation?
all the things.
If you believe that there is now plaque shift, and then we don't know what's going with this diagonal, are you do recrossing first and before doing high pressure inflation in the proximal part of the stent? Because if you do high pressure inflation, it will be impossible to pass another wire to the diagonal, to recrossing the wire, if it's something heavy diagonal. What do you think about this?
Well, the stent is starting at that point, just really below the bifurcation. So we can place high pressure and there will be no impact. The other point to look to be sure that if there is nothing at the ostium, I think the best is to remove the wire, because we know that every time the wire, we change the angle of the bifurcation. And second, you can have some spasm or some accordion effect, etc. So to be sure that, particularly here, when you look at this lesion, it's more critical now on the proximal part of the diagonal than on the baseline angiography. So I think that the final evaluation will be to inject nitroglycerin, remove the wire, and then redo. And if effectively, in different views, it could be AP cranial, aerocranial, or LAO cranial, we think that there is some carena shift from here to the diagonal. We have to finish with the kissing. But if we place a balloon, it should be automatically a second stent, because a long balloon like that in this vessel of 2.5 millimeter, we know the result, unfortunately.
No. I mean, if you, for example, this is near to the ostium or the stent proximal to the, are you going to do high pressure for the stent before recrossing?
Yes. If we cross over the ostium, yes.
Things at your disposal to make sure we're in the stent and away from the ostium of the diagonal.
Correct. It's an important step of the procedure. Now we try to be simple. We have to keep simple.
Simple but careful.
Yeah. Sorry. It's the problem of the treatment of the edge, residual stenosis.
The nice thing with this is that we can see it without having to put any contrast in. I mean, you can see quite clearly that we're nicely in the stent.
Yeah.
Yeah.
Or you can do a stent boost again. Or
You can do the stent boost again? I think it seems to be correct. There is maybe 1 millimeter above.
We are inside, eh?
We are inside the stent, and often the balloon inflates a little bit above the marker, so I think it will be okay.
Yeah, that nicely demonstrates that.
Okay, the 3012.
Yes, 3012.
Quantum balloon. Which version?
20.
20 with the 30. Okay.
It's a long stent, and usually I have the tendency to go with with a non-compliant balloon at the proximal part to be sure that this long stent is well deployed. So, for sure, in clinical practice, we don't use IVUS systematically, and I have the feeling that for long stent, it will require systematically a post-dilatation with a non-compliant balloon. Maybe I will do here a little bit more. Okay. Here there is no concern.
Turn 20 again? Or?
Yeah.
20.
It was the part where there was the most severe lesion. So
Yep.
maybe here there is some resistance. Okay, stop. It's time to control.
Very nice.
It looks very nice. What we can, at this moment, we can redo a stent boost. We re-advance the balloon and do the stent boost to see the proximal part.
So for doing the stent boost, we need the 2 markers of the balloon inside. It's the reason why we
Going back to your previous question, I'm now thinking,
the balloon inside.
I suppose
Second, you
if
can
one had
see in
wanted to be really
this
elegant
example that
and realizing we
we are
weren't going to
doing
cover the
a
diagonal,
stent
we
boost
could have
several
left the
times
pressure
during
wire in the
the
diagonal.
same procedure.
But it's
particularly
interesting to see the
I don't think
the dilatation, pre-dilatation, stent placement, post-dilatation, high pressure, large balloon will change, will modify the result on the FFR. Could be.
Oh, it certainly would do in the LAD, for sure. I'm sure. I think there's good data on that, that the better your stent is deployed.
No, I was talking about the data now.
Yeah.
The result of the stent boost seems correct.
Yeah, I think it's
The
looking
stent
really
is
nice.
Yeah, result of stent boost is very good. It's very nice, and the struts look really parallel. And,
At this point, I think that
just John,
we will do another angio in two orthogonal
wanted
view.
to stent boost. Who has a stent boost? Wonderful, because stent boost is available today only in the Philips machines.
Yeah, it's a Philips machine. I think that GE or Siemens also are working on the
I've
similar
seen
system.